Okay, so I want to welcome everyone to our first biostatistics seminar of this academic year. I'm Rebecca Butensky. I'm the chair of the Biostatistics department. And actually, I still have people coming in, so I'm clicking them into the waiting room. Okay, so I'm very, very pleased to introduce our speaker today, Dr. Loni Philip Tabb. So Dr. Tabb is an associate professor of biostatistics in the Department of Epidemiology and Biostatistics at Drexel University at their Dornsife School of Public Health in Philadelphia. So I've known Loni for a long time. She received her PhD from Harvard in 2010, which means I probably have known you since 2006 or something like that. And it's wonderful to have followed her career over time and to be her colleague now. So she has had a lot of success in with many grant awards and has been involved in many different kinds of research activities. She's also been a very strong advocate for diversity in biostatistics. And so again, I'm really pleased to welcome her and to let her to go ahead with your seminar. Thank you, Loni.
Thank you, Rebecca, and thank you all for taking the time today to attend the talk. And although we can't be in person, Zoom will have to do for the moment. And so I will share my screen so that everyone can see. Okay. Can everyone see the screen okay? Get a thumbs up.
Yep.
Okay.
It's
Okay.
good. Thank you.
Okay. So what I wanted to present today is actually some work that I've been engaged in since the beginning of the COVID-19 pandemic. And although most of my research more recently has focused on looking at spatial and spatial temporal patterning as it relates to cardiovascular health in this country and the inequities between Blacks and whites in this country, pivoting to focusing on COVID-19 was really just a matter of time, right? And so I wanted to talk a bit today about this work, and I've entitled it Assessing the Cases and Deaths as they are attributed. But I put in bold here, are we really all in this together, right? Because if that rings true, then we should not see the stark inequities that we have been unfortunately seeing. So just a brief outline of what I'd like to cover. I know typically in talks, folks save acknowledgements for the end, but I'd like to acknowledge folks in the very beginning, just because I think it's important to highlight who these individuals are and who I have been collaborating with for the past almost 8 months. And then I'm going to lead off with where we are now with respect to COVID, and then take a glance back into how things all began. So I'll discuss some of the different spatial disease mapping methods that I've used and show some results and conclusions, and then talk a bit about next steps. I do hope that the work that I'm engaged in, just like many of you, that it lays a foundation so that then we can create more informed, targeted solutions, right, to address some of these different challenges, and in particular, the racial and ethnic inequities that we're seeing with respect to COVID-19. And then we'll have some time at the end for questions. So as promised, I wanted to acknowledge, first and foremost, all of the many lives and families that have been impacted by this virus, and not just here in the US, but worldwide, right? And then I would also like to acknowledge the Johns Hopkins Coronavirus Resource Center. And that's because without me being able to access this publicly available resource, it would be really hard for me to address some of the different statistical challenges that I was trying to address in the absence of a resource center like this. And then lastly, the different collaborators that I've worked with on this project. So Scarlett Bellamy is at Drexel right alongside with me. She's a professor of biostatistics, as well as Sherelle Barber, who is a professor of epidemiology, an assistant professor of epidemiology. And then lastly, I'd like to also give a shout out to Ruby Bayless, who is currently my doctoral student in our PhD program in biostatistics. So where are we now? Unfortunately, on September 21st, the US hit a pretty grim milestone, right? So if you're not aware, on that day, there were over 200,000 COVID-19 deaths that were confirmed or even probable deaths across the United States. And you know, not only is this grim for us here in the US, but globally, right? This pandemic has touched so many individuals. And so on a global scale, there are over 30 million cases and nearly 1 million deaths. And so unfortunately, this is what we are all experiencing all at the same time, although this is touching everyone across the globe. And so when we think back to, you know, at least here in the US, our first lab confirmed case of COVID-19 was back in January. And specifically, it was January 20th. And that case was confirmed or reported to the CDC on January 22nd. And while we can think back to when things began in January, during the earlier months of the actual pandemic, there were also early reports, unfortunately, of inequities. And so when we think about the different racial and ethnic inequities that existed back in April, mid-April to be exact, there were a number of states during that time that reported data, but at the state level, as it relates to COVID-19 cases and deaths, but specifically deaths, for different racial and ethnic groups. And so most of the states that were reported during that time, Blacks accounted for a higher proportion, right? We saw this anecdotally in the news, and there were some early studies, some early descriptive studies that highlighted this. And so states like Illinois and Michigan, these states were ringing the alarm, if you will, about how things are not fair in terms of the distribution of how COVID is impacting certain communities of color. And during this time as well, in those same number of states, a portion of those states, so there were 26 states during mid-April that actually reported data in terms of COVID-19 as it applies to Hispanics in this country. And only 6 of those states reported at the time, but 6 of those states reported that these communities had made up a greater share of COVID-19 cases. And even though we have struggled as a country to be able to really expose what the racial and ethnic distribution with respect to the COVID-19 pandemic looks like, there have been, you know, findings even at the more granular scales. So in the city of Philadelphia, where Drexel sits, unfortunately, while the city of Philadelphia is known as the city of brotherly love, we've had our own issues as well. And so a data brief recently came out that I collaborated with a number of folks over at Drexel, highlighted how there were these different inequities based on the zip code that you lived in. And unfortunately, racially segregated neighborhoods were the ones that were disproportionately impacted. And so the map here that you see on the right hand of your screen, that's a snapshot of Philadelphia based on zip codes. And it's not as if necessarily what you're seeing is just so random, but side by side, when you look at the COVID case rate in the city of Philadelphia, and then when you also look at the actual racial or ethnic makeup and how segregated certain neighborhoods are, there is an obvious correlation. And so when we think about back to the state level with respect to COVID and more particularly the death rates related to COVID, back in May, we noticed that even though only 40 states and the District of Columbia started to report at the state level the COVID death rate based on these different racial or ethnic groups, Blacks, which are denoted here in this green bar, were far larger in terms of the COVID death rates per 100,000 people. And then not only that, even though this was back in May and it was based on only the 40 states, when you fast forward and you look to say September, we now have information for all 50 states, roughly speaking. And we still see that Blacks, and in addition to Blacks, indigenous populations, Latinos, they have larger, much larger of an impact with respect to COVID-19 deaths. And keeping in mind, you know, even with some of these other different racial or ethnic groups, certain states don't have that in terms of how they're reporting. And so there's always that caveat too, in terms of what is the racial or ethnic distribution as it relates to COVID cases and as it relates to COVID deaths. And this last background slide that I'll show, you know, speaks to an article that I saw that came out in the New York Times right after the 4th of July. And the title of the article was "The Fullest Look Yet at the Racial Iniquity of Coronavirus." And there's one quote that pretty much sums up what the entire purpose of this New York Times article was about. Black and Latino people have been disproportionately affected by the virus in a widespread manner. And whether you're looking at counties in urban settings or suburban settings or even rural settings, it unfortunately rings true in a lot of these different areas of the US and across all different age groups. And so the reason why I think it's important to lay this foundation is because we have to then question, well, why, right? We have, you know, come to an understanding, a lot of us in public health and in medicine, and that viruses don't discriminate, right? But there's a caveat there, right? There are different structures, social and economic, that exist, unfortunately, in this country that exacerbate the impact of the virus that then does discriminate, right? And so when you think about the context in terms of where people of color live, there are these contextual factors that limit their access to healthy foods or increase their chances of being discriminated against, or their dealings with daily and chronic stress simply based on their different interactions, unfortunately, based on the color of their skin. And so Blacks and Hispanics, not only are we constantly have to think about these contextual factors, we also have to know that there's a ton of evidence that already exists with respect to how Blacks and Hispanics are more likely to have these underlying chronic conditions that unfortunately lead to poor outcomes if they are exposed to the coronavirus. And so when we think about, you know, this claim that viruses don't discriminate, we really have to be clear in that we know that, you know, biologically a virus doesn't discriminate, but that there are certain social and economic structures that are in place, and we need to be aware of that. So the goal of this work that I've engaged in over the past couple of months, first and foremost, is to ring the alarm. And so I know that anecdotally and in, you know, the media, whether you are, you know, getting your media from newspapers or if you are getting your information from social media itself, there are folks that are ringing the alarm, right? And so my goal was to, in a pretty systematic way, use various statistical methods to really have an understanding of what is going on with respect to the disproportionate impact. And so the first aim of the study was to simply describe the patterning of the COVID-19 cases and deaths as of April 30th. And I will talk more in detail in terms of why I chose April 30th as the date. And then the second aim of the study was to estimate the actual inequities, the actual racial or ethnic inequities found in these COVID cases and deaths. And so in terms of, well, how am I actually going to do this, right? I had to turn to the Coronavirus Resource Center over at the Johns Hopkins University. And the nice thing about this resource center is that it's there not just for researchers and students like us, but it's there for just the general public, so that that folks can get an understanding of the virus, inform the public, and with respect to policymakers, in order to then give them a way to have more guided responses so that we can really get in front of the pandemic. And so I've listed out the GitHub site. So if you have interest in looking at this data, it is there and it's updated daily, if not multiple times throughout the day, to be able to have cumulative runs of what this coronavirus looks like in the country and globally. And so I was able to ascertain the confirmed and probable cases and death counts attributed to COVID-19 up to April 30th at the county level across all the US. And the reason why we chose to focus on April 30th is because we wanted to get an early assessment of what the racial or ethnic inequities look like in this country prior to the country opening up. So if you'll recall, back on May 1st, that's when there were various reopenings across the country. And they varied depending on what state you lived in, what region of the country you were in, what the community spread looked like. And so there was a not so consistent way of determining how folks were then now trying to get back out into different communities. And so we chose to cut off things at April 30th. And then because we were interested in looking at the racial and ethnic inequities, I turned to the American Community Survey from the US Census. And the most current 5-year estimates that are available are based on the 2014 to 2018 data. And not only did we look at the percent Black and the percent Hispanic at the county level, we also looked at other county level characteristics. So we looked at the percent living below the poverty line. We looked at median house values as well as household income. We looked at education levels. We also looked at percent at least 65 years, given the risk of dealing with even more complications if you are of that age group. And then also population density. And so as I mentioned, we were doing this for all US counties, right? And so there were 3,139 counties. And we wanted to look at not just all of the US, but given how the pandemic unfortunately hit the state of New York in the fashion that it did, we also wanted to look at New York separately. So we looked at the 62 counties in New York as a separate case and looking at all of the US counties. And there was a combination of different exploratory spatial data analysis methods in order for me to deal with that first aim that I mentioned. So Choropleth maps, different Moran's eye statistics, so that I could really have an understanding of, well, when I'm looking at a particular map of the coronavirus cases across the country, am I seeing random patterns, or are there clusters of different, ways that this virus is spreading across the country? And then because we had this long list of potential county level characteristics that would have some sort of relationship with whether you had COVID cases or COVID deaths in a particular county, we wanted to make sure that we minimize the potential for multicollinearity. So we did look at the variance inflation factors to ensure, and all of the county level characteristics that we considered had correlation levels that were small, very, very, very minor. Now, to formally and in a more inference-based way, look at this relationship between the racial and ethnic, distribution at the county level and how that potentially impacts COVID cases and deaths across all counties, we use spatially varying zero-inflated negative binomial models. And the reason why is because although depending on where you sit in the country, you would think that if you look at the news and if you look at, everything that is going on, it seems as though, tons of people are infected, right, with the coronavirus, or tons of people are dying, right, unfortunately, from the coronavirus. But truth be told, especially in the beginning of the pandemic, and definitely before, April 30th, when we looked at the data, there were a number of counties that had 0 counts. And so we wanted to be able to use a count-based model that would allow for potentially having an excessive number of zeros. And then the reason why we considered the spatially varying setting is because while, yes, we think that there are racial inequities when you think about % Black and % Hispanic in terms of the residents that make up a given county, we don't think that there is just one global way to be able to measure that. So the spatially varying type of model that we used allowed us to actually look above and beyond whatever that fixed effect might look like. And so we did this in a Bayesian statistical framework, and we did use integrated nested Laplace approximation, where this method has been shown to be highly comparable and highly correlated with full-on Monte Carlo approaches. And so because we did this, we were able to obtain different posterior estimates as it relates to relative risk and credible intervals. And so in terms of the actual modeling structure, given that we are under this realm of having excessive zeros, instead of using a traditional negative binomial, like I mentioned, we're using the zero inflated negative binomial. And so it partitions out the zeros in a way where you could have zeros that are structural zeros, and maybe in those particular counties, those zeros, or in a sense, those individuals at risk would not be potentially, categorized as either being a coronavirus case or a death related to COVID-19 versus other counties where you may see additional counts. And so in the negative binomial structure of the model, with respect to the general modeling framework, we had different components that we took into account. Our beta naught takes into account that overall intercept, but then beta P here represents all the additional county level characteristics beyond % Black and % Hispanic. And then beta Black with a subscript S and then beta Hispanic with a subscript S represents those varying effects that I mentioned before. And so this allows, almost as if you have a separate intercept for each of the counties above and beyond whatever that fixed effect looks like for % Black and % Hispanic. And then lastly, we are interested in taking into account potential random variation that could exist at the county level. There were so many different policies and different rules and guidelines that different counties and also those nested within states that varied. And so we looked at including county level random effects, and we made the assumption that the county level random effects were based on the LaRue assumption. And so for the LaRue assumption with these county level random effects, we have a variance structure that's a bit more flexible than the traditional conditional autoregressive structure. And so with the LaRue random effects, the variance component has a few different components that are also included. And so the tau beta is a representation of the precision, which is really the inverse of a variance component. So we have precision that is pretty much scaling our variance for these county level random effects. But then when you look into the formula, we have a rho parameter. And what rho is doing, rho goes in terms of its support from between 0 and 1, and it's basically governing the amount of spatial variability that exists. And so the nice thing about a LaRue, modeling structure for these random effects is that it has two components. It does have the identity matrix in there, and that identity matrix is directly relatable and representing the unstructured random effects. Whereas though this Q matrix that you see here, this is representative of what a traditional conditional autoregressive structure is that takes into account neighboring counties. So that if a county shares a border with another county, those two counties are actually neighbors, and they're sharing information between each other through this neighborhood matrix. And so after we took into account these spatially varying, coefficient types of models, as well as the initial exploratory spatial data analysis methods, we gathered all of our results to really see at the landscape level what is going on. And so when we look at this table here, this table represents just an overview of what it looks like at the entire US level with respect to COVID-19 outcomes, for the number of cases and the number of deaths, but then also county level characteristics. Again, this is across all of the US, and it's for the over 3,000 counties that we considered, including New York. And so what you'll notice is that when you look at the median and the mean number of cases or deaths, there's definitely skew, right? And so we assumed that, we knew that there was going to be some potential extra variation here, where when you look at for the cases, for instance, on average in a given county, you have 17 cases. And for the deaths, you have 0. But then when you look at their corresponding means, we see much larger values, much of which, when we look at all of the US, is actually driven by the statistics that we see separately in the state of New York. And when we take into account these other county level characteristics, it's important to have an understanding too as to why, right? So in much of the work that I've done, these different county level characteristics based on race, based on education, based on income, and age in particular here as it relates to COVID-19, these are really important indicators when you're trying to disentangle a lot of different racial or ethnic inequities. Some of the future work we are considering as it relates to COVID-19 is to look at that intersection between race and income, because what that intersection will allow for is really a true understanding of the residential segregation makeup, especially given what we've already seen at the local level with respect to Philadelphia. But that's for work to come. This second table here shows specifically just for the state of New York. And so as you'll notice, when you look at the max number of cases and the max number of deaths, this is what was driven, this is what was driven when you looked at all of the US, right? And so in a given county within New York, the number of cases at that time by April 30th was up to just shy of 168,000 confirmed cases, cumulative confirmed cases. And then similarly for the deaths, a little over 18,000. And so again, us trying to really disentangle what's going on, given the impact of the pandemic on the entire state of New York, this gave us even more of a reason to separate out and then to be able to really see what's going on at the state level. These two maps here, the one on the left shows the geographical patterning of COVID-19 cases. Again, up until April 30th. And the one on the right is related to the deaths. And this is including every county, all of the 3,139 of them. And with respect to the legend, I know it's probably small, but it goes from 0, which is denoted by the blue shaded counties, all the way up to over 1,000 COVID cases per 1 million in terms of the population. And that's indicated by the darker red. And so during this time in April, you know, we knew that in the Northeast that there was going to be a significant amount of clustering given how things happened in New York, but also there were regions in the Southeast, and in particular, say the Louisiana area, where we were starting to see hotspots, right, that were starting to pop up. And then similarly, when you're looking at the actual deaths in the map to the right, we know that we expected to see higher death rates in the Northeast But then again, things were starting to cluster in the southeastern portion of the country. And what's interesting about COVID-19, especially as it relates to some of the other work that I do with respect to cardiovascular health, if I were to overlay a map on top of these maps as it relates to cases and deaths with respect to cardiovascular health, there would be a lot of similarities with respect to poor cardiovascular health, especially when you start looking at hotspots within the Southeast. And that's because of areas like the stroke belt and the stroke buckle, where unfortunately in those parts of the country, you have even greater incidence of cardiovascular health, poor cardiovascular health factors. So whether that's increased risk or increased rates of stroke, diabetes. And so it's interesting that when you look at COVID-19, although this is a novel virus, unfortunately, it is mimicking in certain parts of the country patterns that we've already seen, especially with respect to racial and ethnic inequities for cardiovascular health. So the maps here, as you know, this is for New York. And the thing about New York, if you'll notice, there are clusters of greater COVID cases per 1 million in the southeastern portion of the state, right? But what you'll also notice is that there are larger numbers of cases, especially up through April 30th and during this time. The death rate within the state as well, in that southeastern portion of the state, was high. But then when we did test out to actually see if spatial patterns were emerging, the test did not result in significant patterns emerging. And so although we still use these spatially varying models for the state of New York, because we were also interested in doing that for the entire country, we still had to keep that in mind. Now, after fitting some of these spatially varying coefficient models, the first couple of slides that I'll show you are going to be related to all of the US, including New York. And what we also did was we ran a sensitivity analysis in some of these more, in some of the actual models that we ran that was for all of the US, as well as the US excluding New York, to see how much our results changed. And they did not change significantly when we were modeling. Of course, when we were doing the descriptive and exploratory spatial data analyses, those were different. So here, this figure is showing the actual point estimates, so the relative risk, as well as the 95% credible intervals for COVID cases. And this is for the entire United States. And it's based on all 3,139 counties. And what you'll notice is that when we look at percent Black in a given county, we're noticing that there is an increased risk of 56% of having coronavirus cases. And this is significant. And while we see somewhat of an increase when we look at percent Hispanic, we didn't necessarily find this significance when we're looking at these different estimated relative risks. But we found that population density, median house value, median house income, as well as education, as those increase, there is an increased risk of additional coronavirus cases, all at the entire US state level. Now, when we look at deaths, as it relates to all of the US, we did not have any increased or even decreased, relationships that we saw. And we anticipated this because although when we think about all of the vast number of cases that exist within the country, the deaths at that time were not as much as what we've now experienced, especially given the milestone that we, approached on September 21st. Now, these next two slides relate to similar modeling, except now it was specific to the state of New York. And so what we have here is that for counties with increasing percentages of Blacks and counties with increasing percentages of Hispanics, there is an increased risk. For Blacks, there was an increased risk of 41%. But if you'll notice, for Hispanics within or counties with increasing percentages of Hispanics, there's almost a threefold increase. And so this increase was much stronger than what we've even seen, you know, at the more grand level when we look across the nation. And while things like poverty and even population density, although population density did look to be a bit marginal in terms of the significance, did not necessarily impact in a significant way the number of cases. These are things that we still noticed, right? And so even when we look at median house income within the state, there's somewhat of a marginal relationship that's there. But given the smaller number of counties in New York, when we look at a separate analysis just based on New York, it's not surprising. Now, if we then switch gears and look at COVID-19 related deaths in the state of New York, we know that there's increased variability here. I mean, we can see that when we start looking at the width of these credible intervals, but population density was one of the key drivers, right? And I'm sure that at least I know when listening to some of the different reportings on the news or even readings in newspaper articles, that population density has played a significant role in trying to understand its impact basically on coronavirus cases as well as deaths. So we weren't necessarily surprised at this significant finding as well. So I want to talk now just about some of the different conclusions, some of the different things that, you know, once we put all of this information together, trying to really hone in on, well, what did we actually land on, right? And so, as I mentioned a few slides ago, Black race at the county level. So when we're thinking about, you know, how we were able to actually ascertain this, you know, get this actual data, and when we think about race ethnicity, keeping in mind this is all at the county level. So percent Black, percent Hispanic, these are all ways for us to gauge the racial and ethnic makeup of a given county, given that we do not have individual level data as it relates to coronavirus cases and deaths for these different things, right? And so Black race was associated with increased risk. And when we say it's increased, it was increased whether we looked at all of the US together or if we looked at New York separately. And this was on a scale of 56% and 41% in both of those settings. And then when we think about the inequities related to Hispanic ethnicity, there was also an increased risk. And this risk was threefold, right? The relative risk that we reported was on the scale of about 2.6. And that's for the COVID-19 cases in New York State. And we did find that the additional county level factors were also important. So whether you're talking about population density, especially as it applied to COVID-19 deaths, but then other neighborhood contextual factors. So median house value, median household income, as well as education, right? And so when we thought about, you know, the findings and we thought about, you know, the pretty systematic way that we went about trying to look at these racial and ethnic inequities, our findings were consistent. It was consistent with others who, whether you think anecdotally or at least from the reportings that we've all seen, or also formally in the small number of studies that currently exist with respect to observing these inequities. And so the one thing I wanted to highlight, the image that I have here on the right is an image from the data brief that myself and other team members that we came out with that looked at COVID-19 in context. And the COVID-19 context brief focused on racism and segregation, as well as racial inequities as it relates to COVID-19 in the city of Philadelphia. And the image here was to highlight that there are systems that are already in place where, unfortunately, racial and ethnic minorities, they are finding themselves and have been finding themselves for a long time now, even before COVID, in essential environments. And I put essential in quotes because we all now know that essential workers are the ones that have been keeping us all afloat, right? So whether you think about your Amazon delivery that comes, whether you're thinking about, going to the supermarket so that you could feed your family, these essential workers were still operating all throughout the pandemic, even during these times when, the country was shut down. And so whether you think about housing, whether you think about transportation, different types of employment, it is really a cyclical way of being able to think about the different contextual factors at play when you start thinking about racial and ethnic minorities and how they've been impacted by COVID. And so unfortunately, in these essential environments, the individuals that work in these types of fields, unfortunately, do not have sufficient protection, right? And so because of the lack of sufficient protection, it's increasing their risk, as well as, just simply they're being more exposed to the virus. And the CDC reported recently that 43% of Black and Latino workers, compared to 25% of, say, white workers, are actually employed in service and production jobs. And these service and production jobs are considered essential. Now, in terms of the strengths and the limitations of this study, I'd like to think that, the work that I was leading, the efforts that I was leading here allowed for both exploratory as well as inferential spatial statistical methods, right? A lot of what I've been seeing has been more exploratory and somewhat anecdotal at times, because it seems as though everyone now is an expert in disease mapping, right? And so whether you watch CNN, Fox, you go on Instagram, everyone is trying to really graphically show what's going on with COVID. And I think that it is good in the sense that the motivation there to be able to get the information out there is key, but I also think that there are pretty rigorous ways that we need to focus on doing these types of things. And then I also think another strength in this work is that, we were able to make use of publicly available data. And not only was it publicly available data, it's up to date and it's timely. As I mentioned, at the Coronavirus Resource Center at Johns Hopkins on their GitHub site, that information is updated daily and throughout the day. And so if you want to get an up-to-date snapshot, or even at different points throughout the year or different points throughout this pandemic, what the landscape of COVID-19 looks like, you're able to do that. And of course, with any study, there are limitations, right? And so the thing about COVID-19 and even the diagnoses, they are limited, right? Because the thing is, there are different barriers that might exist in terms of whether or not someone actually does go and obtain a COVID-19 test. So whether that's language barriers, insurance coverage, or just simple surveillance of this pandemic. And so the racial or ethnic cases and deaths are not reported necessarily in a consistent fashion on top of that within and across states. So that's another limitation that presents itself. But I still think that the data that's found in the COVID-19 GitHub repository from the Johns Hopkins Coronavirus Resource Center is still pretty awesome data to be able to look at how this pandemic is evolving. And then the bottom line here is that, you know, the findings that, so everything that we found, right, it highlights that disproportionate burden of COVID-19. And unfortunately, it's on communities of color, and in particular in counties that had increasing percentages of Blacks and Hispanics. And so, you know, I'd like to think that what we've done so far is to ring the alarm. This work is currently, you know, under review. And so I'm hoping that the information can continue to get out there. But not only that, when I'm thinking about, you know, next steps, it's really imperative to really see, well, given that anecdotally, really early on, there was evidence that showed that there were racial and ethnic inequities as it relates to COVID-19 and its impact, looking at the spatial temporal changes in these different inequities is also key, because you would hope that although things looked as stark as they did before, say, May 1st, when the country opened up, you would hope that things would have changed. And I'm not saying that that's necessarily the case, but we don't know, right? And so I do think that a spatial temporal examination is probably what's next to consider. And when I think of spatial temporal settings, I think of natural experiment types of study designs, right? Because we could take a look at how things are from January, that first case that was reported to the CDC, up to the most recent, say, milestone that we crossed in having the 200,000 COVID-related deaths, and looking at different time points within the year to see, are there any impacts on these different inequities? And on top of that, what about the actual interventions or policies that have been put into place? Have they done what they were intended to do, right? So even though Drexel University is in Philadelphia, myself and my family, we live in Delaware. And so here in Delaware, we, regardless of what county you live in, free COVID-19 testing has been available since early on. And so when I talked before about the different barriers that exist, that did not place itself in terms of the barriers, right? And so, you know, I say all that to say that every state operated under different norms and different policies and guidelines. And I think change point types of statistical frameworks are a really good way to be able to assess if the different racial or ethnic inequities that existed early on in the pandemic have either stabilized in certain areas or you know, diminished a bit, or unfortunately increased. It's still left to be seen. And so I've listed here a ton of resources and references as it applies to the presentation. And now I will take some questions.
Great. So thank you so much. So now you need to imagine that we're all clapping in appreciation for your wonderful talk. So thank you very, very much. And actually doing it in the Zoom way as well. So questions, please, if anyone would like to jump in with a question, please go ahead.
Oh, I do see that someone asked for the Johns
The
Hopkins
link, and I think somebody gave it also.
Oh, did they give it? Okay. Okay.
Yeah. So
this is recorded, so it's also available for people if they need. Okay.
Right. That's right. Thank you.
Okay.
So I'll ask you a question. So on going back to your slide where you had, you know, the results, like the forest plot, were you showing that increased education? So go back another one maybe, and go back another. Okay, there you go.
Oh, this one right here.
Yes. So maybe I'm reading this incorrectly, but are you suggesting increased in median household income, increased house value, increased education,
Yeah.
greater risk? Is that, and how do you interpret that?
So I think that when we see things like median house value or median house income and education, this is speaking to those individuals who do not have those barriers where they can get tested. And so not that necessarily this is in the manner that we might see, say, in other areas with respect to different inequities, but I think it's a matter of who is actually able to get tested.
Oh,
And then out of those who are able to get tested, the percentage of people who are positive, right? And so I think that's what's going on.
I see. Okay, interesting. So, and this is this is the multiple regression model. So all of these are in the same model.
Yes.
So is it possible that some of the other factors, like percent Black or percent Hispanic, are also capturing sort of the lower end of, you know, like the low income or the low house value or the low education?
Yes, so that is very possible. And that's why I also mentioned early on that we'd like to actually look at measures that would be able to really disentangle, because when you think about something like, say, residential segregation, that could have been something that we considered. And with residential segregation, it's really a measure that focuses on the racial or ethnic composition of a neighborhood or of a county. But when you think about racial segregation, you can't tease apart the social economic side of things. And so there are measures. So Nancy Krieger from Harvard School of Public Health, she has created more recently a measure, the index of concentration at the extremes. It's the ICE measure. And what that does is that it allows for you to look at the racial or ethnic composition of say a county, but then not look at that separately, but look at it in conjunction with, say, poverty levels. And it moves beyond simply including, say, an interaction term between, say, you know, percent Black and, say, percent living below the poverty line. It really does look at those extreme ways of looking at whether it's, say, white privilege versus Black low income and vice versa, right? And so I think that that's next in terms of what we, you know, are interested in really trying to disentangle moving forward.
Great, thank you. Any other questions from anybody?
I had a question, I put it also on the chat, on ridership and whether we can tell, because there was a report that the ridership in New York fell even through February before anybody was alerted on anything. Like people like started acting on a cautious, on a cautious mindset framework, and I was wondering whether we can tell which boroughs, which communities the ridership fell, and what was the progression of that reduction in ridership, which possibly could be, you know, the main avenue of contagion.
So you're getting at transportation, and I wasn't aware that it was in February that the state, not the state, that the city made this call. I do think that that's an important factor to consider. And so when I was thinking about the spatial temporal aspects, I do think that those are the types of policies and, you know, different guidelines that go into place, but in different localities. And so if there is a way for me to be able to really operationalize that, I could look at that. I could definitely consider that. Because you're right, I do think that, and it's funny you mentioned that too, because I know early on in the pandemic, say in the city of Philadelphia, one of our major transportation providers, SEPTA, there was a significant push to, you know, first stop ridership. And after that push, you know, folks had to take into consideration these essential workers who also needed to be able to take advantage of transportation. And so I say all that to say that there was a period of time too in the city of Philadelphia where, you know, when you think about transportation and the different policies that were put into place, and this push and tug and pull between mask wearing, it became a struggle. And it really did impact how people were moving about within the city. So I think it's definitely worth considering especially taking into account that temporal patterning, since we'll be able to, say during this time, we're able to look at, COVID cases before versus after, or COVID deaths before versus after.
By the way, to clarify, the city did not take, actually until March, the city officials were urging actually communities of color to go on parades, to use the subway. De Blasio famously rode the subway, and he said, oh, it's safe, people can use it. So actually, but the people themselves, despite the government's lack of guidance, decreased the ridership. So I'm curious as to which communities took that cautionary path and which communities over-relied on the government's local, state, and federal lack of clarity.
Right.
I'm curious to that connection as well.
Right. Right. No, thank you for that. And that was, just to clarify with you too, that was at the city level, but then, okay.
Any other questions from anybody?
I have a question. Hi, so Loni, I really enjoyed this talk. This is wonderful, very interesting. And especially I'm interested in the component of modeling spatially varying covariant coefficient in the model. Mm-hmm. I wonder what the input information will look like and how those spatial information can be taken into account when you specify the Q matrix. That part is not very clear to me.
Yeah. So the first thing that you would have to consider is how you define a neighborhood structure. And so here I made the assumption that in order for me to get this neighborhood matrix for whether I'm dealing with the 62 counties in New York or if I'm dealing with the over 3,000 counties in the United States, it's a square matrix that says for a given area, for a given county, what are the neighbors? And so I made the decision to use a neighborhood structure based on sharing a border. And so there are other ways to make assumptions. You could look at the centroid of each county, and if it's within a certain distance, then you consider that a neighbor. I did not do a sensitivity analysis to see if things would vary so much based on that assumption for the Q that's related to the, within the LaRue random effects.
Okay. Okay, thank you.
You're welcome.
Good. All right. Well, I think we're at the end of our hour. So thank you to everyone for joining us. And thank you so much to Loni for a fantastic talk and for joining us virtually. And we look forward to inviting you back when we can all be in person again. So thank you very much.
Thank you.
Okay. Take care, everyone.
Bye.
Thank you.